I would just like to start with a brief review of where we are and where we're going. And if you were here last time, none of this will be a surprise, but I do think, it's been a couple weeks since we've met, so I think it'd be probably useful to everybody to hear it again. But the overarching goal of this group is to present issues to the co-chairs that would be considered as priorities. And we hope to accomplish that, by September, and I think we're on track to get that done. And as we discussed on July 6th, there's really 3 steps that we need to take that will get us to that overarching goal. And at least it's easy for me to think of it this way. The 3 steps are: we need to hear and then discuss issues presented by the researchers, or researcher issues, and then those from participants, which is you. So, and we do have a participant issue that I will talk about in just a moment. And then the third step, then is a survey that each work group member will be asked to complete. And that survey is being developed right now. And we hope to have that out for everyone to take by the middle of August. And keep in mind, this process is not just a process for this work group, it's the same for all 3 work groups. Those other 2 work groups is education and life skills, and then income and stability. And that survey will be taken after we have our 3rd meeting. And our 3rd meeting, and our last meeting, then would be on August the 11th, okay? And hopefully you already have that on your schedule. So then with each issue, then there's really 3 activities. One activity is to hear a presentation on that issue. The second activity is to talk about that in small groups using the criteria that's been established. That criteria is in your red folder. It will also be up on the screen. And then also what happens in those small groups is that you need to take copious notes, as we always say. And it's important that you take those notes, because when you go to respond to the survey, it will be very helpful for you to have those notes with you when you carry that out. Okay? So 3 steps involved, and then there's also then 3 activities for those issues that we're going to talk about. Okay? So we started the first step, and the first step is researcher issues on July the 6th. We heard 4 of the 6 researcher issues that have been advanced. And if you weren't here, and if you were here, you will recall that those 4 issues that we heard about and then discussed in small groups included chronic diseases, access to food, substance abuse, including both alcohol and opiates, and then the last one is brain health, which also included depression and anxiety. So we heard presentations on all 4 of those issues, and then we broke up into, I believe it was 3 groups, and we talked about those in small groups. Okay? So, what's next? Well, we need to do the large group discussions then on those 4 issues, and then we need to repeat the process for those 2 remaining issues. And that's what we're going to do today. Okay? Now, the large group discussions, we will limit to 10 minutes. Okay? So if you go through the math on that, that should take us to about 2 o'clock. Okay? And then that leaves us the last hour to cover those 2 remaining issues: birth outcomes and violence. And Sarah Payton will be presenting on birth outcomes, and Jane Dockery on violence. Am I wrong?
I'm probably going to have my new colleague Angie present for us.
Okay, new colleague Angie will be presenting on violence. And then we will break into the small group discussions. Remember, we limited those last time to 20 minutes. We may have cut the last one a little bit short because we ran out of time. And then we'll be done for today. The thing that I want to talk about before we have the large group discussions, is that also on July 6th, we solicited other issues that you believe are important and should be considered as priorities by the co-chairs, but were not presented by the researchers. And I'm happy to report that we actually got participant issues from 2 work group members, and I hope you guys don't mind. But Michelle Pierce Mobley submitted an issue on autism, And then Susan Caperna submitted an issue on fetal alcohol spectrum disorder. Pardon me? Autism. And we, first of all, really appreciate that they submitted those issues. Both of those work group members will be receiving extra credit and additional time at recess in our next meeting. But what we did is we took those issues and then we asked the researchers to weigh in, and also asked the co-chairs to also weigh in as well. And I'm happy to report that it was a unanimous decision that those two issues will be combined along with other disorders and will be an issue and will then be considered the 7th issue for this group. And that will be presented at the August 11th meeting. Okay? One of the researchers will probably present that. But at that meeting, we will have the issues presented. We will do small group discussions, and then we will also do large group discussions. So we will do all of that. At that last meeting, we will also have a large group discussion on the two issues you're going to hear today. Okay? So if you go through the math on that, that last meeting will be shorter, relatively shorter than these meetings that we're having, probably about an hour. Okay? So I think I've covered where we are and where we're going. So again, today what we're going to do, and again, we're still in that first step because we're still on researcher issues, okay, is we will have a large group discussion on those first 4 researcher issues that we talked about on July 6th. And there are 2 main questions. Here's the 4 issues again. And then there's 2 main questions that's coming up that we really want to answer in this large group for each of the 2 issues. And just let me tee this up a little bit. It's an example we've used many times in our facilitator discussions, and that is when you're in the small groups, and again we have 3 small groups, and if we use, for example, an issue of substance abuse, and let's just consider opiates. At our meeting on July 6th, there were 3 small work groups talking about that. And I believe Chief Beal was in one group, and Sheriff Plummer was in another group. And they probably shared a perspective with you that may have been somewhat unique. May have provided you with some information that you otherwise would not have because they are both the law enforcement chiefs of this area. What we would like for you to do is if there was something like that that you believe the rest of the group would benefit from, that you share that right now. So any information that you believe was a unique perspective that you would like to share that what happened in your group. Then the second question, or the second point, is that if you believe that you were in a group and there was a perspective that you believe was missing. So let's say you were in that 3rd group on July 6th, where neither Chief Beal nor Sheriff Plummer were in, but you really wanted to know from a law enforcement standpoint, what did they really think? Well, you didn't get that. I don't think they're here today, so you might not be able to get it today either, okay? But that's what the purpose is of this large group discussion, okay? Again, 10 minutes per issue. We should be done in 40 minutes.
Okay, so the issue is very simple. Our babies are dying. Our most vulnerable citizens, our future community are dying at a rate higher than anybody else in the country. I don't know how to make it any more clear than that statement right there. We have, if you look at the data, and trust me, I'm an epidemiologist, I look at data, and I look at data for all issues. There is no worse data than our birth outcomes in Ohio, and Montgomery County is no different from Ohio. We rank, for infant mortality, we rank 46th. 46 out of 50 states. And if you look specifically at races, our African American babies, they're last. They're 50th in the country. There's no place in the country where African American babies have a harder time reaching their first birthday than in Ohio. And people always, some people find this as a surprise. I've presented this to many people. But this is the data, and we can show it in all sorts of different ways. Here we have some data for Ohio on this first slide compared to the US and what's been happening. This goes back to 2000. You can see that our data has been stagnant in Ohio since 2000, where the rest of the country, more babies are living, more babies are making it to their first birthday, we're stagnating. And if I've done the research on Montgomery County, we can go back to 1991, which is the earliest data I could find electronic records for, and our data is the same in 1991 as it is today. That's 25 years where we've made no improvements in infant mortality. So one of the next big questions that comes up to me is, why are our babies dying? So go to the next slide. Thank you. So if you look at the cause of death on the death certificates, which I do, the top two things that you see that causes our baby deaths are prematurity. So a baby is born too early, or it's born too small, or it's congenital malformations. They're born with something that doesn't allow them to live until their first birthday. And there's also other big things in those top causes of death. Safe sleep issues are part of that as well. Maternal health complications is in there. There are a lot of things. But those are the big causes of death. Those are the medical causes of death. What this iceberg is reflecting is that that's just the tip of the iceberg. What's causing all those deaths is what's all under the water. And it's all these things that we've been talking about in all the work groups. It's poverty. It's education. It's smoking. It's poor environments. It's access to food. It's substance use. It's stress. It's depression. All of these underlying, below the surface issues are impacting our birth outcomes. Our babies are impacted by all these things that we've been talked about. That's what's causing all these deaths in our community. So this is a big issue. This is a hard issue, but this is an important issue because, and the legislators have taken notice. Our Senator Jones is very big on infant mortality. The state has initiatives for infant mortality. Medicaid is focusing on it. Hospitals are focusing on it. And, part of me is happy that it's done, but other people here that have been sitting around the table talking about this with me for years and years, and this finally, Ohio is starting to get some momentum. We need to do something about this. So, what do we do? This is important. This is another thing to think about is infant mortality. It's an overall health indicator for our community. When people are looking at our community to see how healthy we are, this is one of those things that new businesses pull out, that people moving here pull out. They look at your infant mortality, because infant mortality, it's looking at, and I've listed here so I wouldn't forget, it's not just prenatal care. We've known prenatal care is very important, but it's more than prenatal care. It's your environment, it's your stable housing, it's adequate food and good nutrition, it's income to sufficiently raise your family. And as that relates to infant mortality is used as a barometer on how healthy your community is. So I think that's within my 5 minutes. I could go on and on about lots of different data to support what I'm saying, but I think that message is clear. That this is something that impacts all of us. whether we've had a death in our family or not, we've all been impacted by this. The disparity data is there. Our African American babies are dying at 2 to 3 times higher rate than our white babies. And we know that that's not a race, that's not being African American that's causing that. There's not something biological that is causing that. If you bring babies, and what this references, women from Africa, when they first come to America, if they immigrate, their babies are born and healthy as a normal rate would be. It's after the next generation that they're born that the disparities begin. It's after those babies. So there's something in America that is affecting the rate. A white woman with low education, teenager, has a higher, has a better infant mortality rate than a well-educated African-American woman. This is what we call the life course approach, and this is a theory put out by Michael Luke, who is the head of HRSA, one of the big health agencies in the U.S., and it was put out in the early 2000s. And this is looking at what's going on here. And if you look here, across the bottom is the life course of the woman from the time she's born. She's in her mother's stomach to the time that she's having babies of her own and onwards, and then the reproductive potential of that woman. So if you look here, we have an African American woman and a white woman. We have a lot of things throughout our life that affect our health. Our immunizations, our nutrition, our education, our support system, our fathers, all of this. And what the life course theory is looking at is that your potential has to do with all these risk factors throughout your life, not just when you're pregnant or right before you get pregnant, that affect your overall health, that push you down. And conversely, obviously there are protective factors that push you up. And the disparities here are, you can largely categorize these as the African American women have a lot of risk factors pushing them down. And if you go into a pregnancy and you haven't had proper nutrition for many years, you haven't had proper health care, you live in an abusive situation, or you have some very stressful situations, whether it's income or whatever, all of these things affect your biological process and make it more likely for you then to maybe have a low birth weight baby, where they're born too small, too early, and those babies are one of the biggest contributing factors to our infant mortality rates. So to actually make a difference in infant mortality, we have to push this all back. Prenatal care is very important, but it has to happen before prenatal care too. We have to get our community healthy. We have to get all women, we have to get our little girls, we have to have our men involved in their lives. There's lots of issues. It's a big issue. And it's something I've been trying to tackle with various people in the room for a few years here, but
I don't know if I can say something. Where I work, we have the nurse-family partnership, and it works really well with this kind of intervention. And Ohio just hasn't supported funding it very well. So we used to have 24 nurses. We used to have 700 girls in our program, and we now have about 200. And we only have about 10 nurses doing it. We just hired 2, so we have 10, but we would have had 8. Anyway, Indiana and Michigan have added tons of, Michigan's gone statewide with Nurse Family Partnership, and Indiana, it was just in the news this week that they already had 3 teams of nurses, which means they had 24, and they just added 8 more. And that's because they're seeing an impact. They're seeing a difference. But you can't put 8 nurses and expect to change our whole community. We can't serve enough people to change the whole community with 8 nurses. We have to have more funding than that. And we have to have people referring the clients to us, and, But the nurse does work on all of those things that you were just talking about. They work on life skills, they work on nutrition and health and breastfeeding and how to care for a baby and what to do with your own life, because if you can't control your own life, you're not gonna be able to raise a baby well. I mean, they do all that, and it lasts until the child is 2, and it starts before they're 28 weeks pregnant. So it's, 2.5, 3 year kind of commitment.
Let's take one more question, and then we'll move on.
Not a question, just a statement.
Okay.
Something else we talked about, Michigan and Indiana and Ohio. Another strategy that Indiana has employed is they are following the footsteps of Finland, who had like the worst infant mortality rate of any country, and started giving every mother that has a baby box. The baby box is filled with things that they need. It also tells them that the baby needs to sleep in the box and with nobody else, and so it goes to that safe sleep piece. Babies who are born within 12 months of a sibling oftentimes sleep with their sibling. This really increases, beyond just sleeping with adults, also sleeping with their siblings also, they're saying increases that. So Indiana just started doing that, so I'm sure there's no results on how it's working so far, but they did implement the baby boxes.
Thank you, Melanie. Do you have one more thing?
No, I was
You
just
look like you're
gonna,
ready.
Jane gave me my data that
Okay.
from the community health assessment. 25, roughly a quarter of the deaths are to short gestation, low birth weight, preterm births. And about 22% are due to congenital malformations, 11% accidents, so that includes safe sleep issues. And then things like newborns affected by maternal complications of pregnancy. That would be gestational diabetes, other things like that.
Okay, so you had the expert on infant mortality. You do not have the expert on violence. The gun violence topic, we did reach out to Jack Dustin, who recently retired. Couldn't get him to come in for it. We reached out to the City of Dayton Police Department and didn't have too much luck getting data that way. And so we went to the public domain of data, and that's what you'll see from us today. We've got a map behind you that kudos to Don, who developed this map that is just a presentation of the geography of a key variable of violence, and that's homicide. Just to give you an idea of what is the geography of it. And then Angie is going to present some detail about gun violence and domestic violence. You should have those handouts with you. We just have this one slide. So otherwise you want to keep your narrative in front of you. Now Angie's just new to our group, but she has her master's in public health, and this is a public health issue, so you have an expert in public health to present the data.
So I'm going to try to keep this short, but I was going to start with the gun violence initially. So we used the National Violent Death Reporting System, NVDRS, and from that we found, in 2012, the state of Ohio had around 1,200 firearm-related deaths, and that translated to about 11 people per every 100,000. Males were 6 times more likely than females to suffer from gun violence. That was about 19 men as compared to 3 per 100,000. For both sexes, Black non-Hispanic individuals were disproportionately suffering from gun violence more. Among all the races, 25 to 29-year-olds suffered more than any other age group. Among females, it was 15 to 19-year-old Black non-Hispanic females had the highest rate. And among men, it was 25 to 29-year-old Black non-Hispanic men who had the highest rate of gun violence deaths. This was for all of Ohio. So among all the counties, Montgomery County suffered the highest firearm-related death at 28.5 deaths per every 100,000. Between 2010 and 2011, it was reported there was about 1,700 firearm-related incidents in Montgomery County alone. And if you look at Table 2 on the paper, you'll see the aggravated assault rate, and this includes all weapons, not just firearms. But you'll see that it has declined in Dayton, but if you look at Table 1, then you see that Montgomery County is still above other counties, with only Hamilton County following closely at 26 rate, a rate of 26 per 100,000. So if you look at table 3, you can see that even though aggravated assault rates have declined over 27 years, homicides using firearms have actually risen by about 41%. So just considering, we were discussing limitations to data, there is some limitations to gun violence data. There is the congressional ban on gun violence data, gun violence research, so that kind of limits what we can find out. The fact that reporting this for Ohio is voluntary. The NVDRS database only reports from 18 states, I think it was. So caution should be used whenever we're interpreting this because we're not sure exactly how many gun violence is, if it's less, if it's more, but this is just what we have reported. But that doesn't mean we can't ignore it, of course. Clearly it's a mental and physical public health issue. The APHA suggests better surveillance. So right now, NVDRS is the only one collecting data, and it was 18 states. Ohio is one of them. Other best practices, of course, is more research. With the congressional ban, that's kind of difficult. But on the APHA website, there's more information about gun violence. So now I'm going to segue into domestic violence. So domestic violence is the most common form of violence. It disproportionately affects women across all ethnicities, sexual orientations, beliefs, everything like that. In 2012, there was 17,912 new filings for domestic violence in Ohio. In Montgomery County alone, there were 1,600 new filings, and that's about at a rate of 298 per 100,000 individuals. This results in the highest rate among all urban Ohio counties, and this is 3 times the rate that we saw in 1996. The number of new filings doesn't reflect the total number of incidents in Ohio or Montgomery County, but it's just the total reported cases. So emphasis on the reported part. Seeing as many victims don't always report incidents of domestic violence, this may be due to social stigma, taboos, feeling of shame, bias in the legal system, whether it's gender bias or policies shifting the blame or putting the burden of proof on the victim, or just a general lack of understanding or education, as we've mentioned before. And although we cannot measure domestic violence definitively because these are only reported cases, there is research to support that domestic violence is kind of an epidemic public health problem. And this is not because it's not only physically or emotionally affecting the victim, but it's also affecting the community and the perpetrators. So, there are so many issues connected to domestic violence, reproductive issues, sexual health issues, disability, depression, suicide. And we know that children who do experience domestic violence are more likely to be in an abusive or violent relationship, and that's either as the victim or as the perpetrator. So this makes it kind of hard to break the cycle. So in terms of effective programs about this, a good resource is the Domestic Violence Evidence Project, and I have a link on the paper. And this website is still under construction, but it has a collection of programs and practices that are evidence-based, and they are more geared towards community practices instead of individual domestic violence practices. And that's all I have about it. And this just shows you a map of where all the homicide deaths are concentrated within Dayton and Montgomery County.
First of all, I just want to thank you for coming today. I think the last time we pulled you out on the day after the 4th of July or something like that, so then we backed it up with a Friday afternoon meeting. We're pretty mean, sorry about that. But we truly appreciate you coming and participating. Please keep in mind, we have a 3rd meeting. The 3rd meeting will be on August the 11th, and it will probably be for roughly 1 hour. The time of that meeting escapes me right offhand. It's late, isn't it? Like 3? 3. I think it's 3 o'clock. I'm guessing we'll probably be done close to 4. At that meeting, you should be able to predict this now, we will have a large group discussion on birth outcomes and violence. And then we will have a presentation, small group discussion, large group discussion on our participant issue, neurodevelopmental disorders. Okay? You may hear that the other two work groups will not be meeting for a third time. But you are. Because you're special. Okay? You need to meet for a third time because you have 7 issues. They only have 5 each. And you have a participant issue, and they didn't. The only participant issue came from this group.
That's excellent.
So, yeah, it's fantastic. So, also, I think there's a lot of really tough, complex issues in health and safety, and, you know, narrowing it down to 7 is phenomenal for what you've done. So, again, thank you very much. August the 11th, 3 o'clock. You probably have 2 hours on your calendar. We'll probably only go roughly an hour. And Commissioner Foley, anything else? Thank you. Heath, anything?
If you haven't put it on your calendar, make sure you have 1 o'clock to 5 o'clock on September 23rd. That's an eon from now. And have it on your calendar if you would. That's when we're going to bring everybody back together for the survey results and the last discussion of this part of the process. Make sure it's out there. Good job, everybody.
Anything else? Thank you very, very much.